The treatment landscape is highly evolving, and with the orexin receptor 2 agonist, we are lucky to really improve care of the patient, to improve quality of life, to really decrease the burden of the disease. And I think that will be a key game changer for the management of the patient in the coming months. In this video, we will explore the evolving treatment landscape of narcolepsy type 1 through a clinical vignette of John, from the diagnosis to treatment. And at the end of the video, you will better understand the pathophysiology and how to best treat a patient with narcolepsy. So let's start first with John. He's a 28-year-old male with narcolepsy. We diagnosed 5 years ago, and he developed the symptoms at around 20 years old, very typical symptoms of severe daytime sleepiness with a sleepiness scale around 19. He did have a daily cataplexy, partial and generalized cataplexy, 3 to 5 per day. He did have sleep paralysis, fragment nocturnal sleep. We did confirm the diagnosis with polysomnography and MSLT, showing latency around 3 minutes and 3 REM. So the diagnosis was clear. We started the management with modafinil because the main complaint was sleepiness. And after a while, we add venlafaxine to treat cataplexy as well. It was okay, but after a while, cataplexy started again, and we decided to switch from venlafaxine to sodium oxybate, in addition to modafinil, who works quite well on daytime sleepiness. I want now to update you about the pathophysiology of narcolepsy. We do know since 20 years right now that narcolepsy is characterized by the loss of orexin neurons in the brain. And as a consequence of this loss of orexin, there is instability of wakefulness and REM sleep regulation. So that explains, the most important symptoms of narcolepsy, namely sleepiness, cataplexy, sleep paralysis, hallucination, and disturbed nighttime sleep. And the drugs we do propose for the patient nowadays act downstream of this deficit, either by promoting wakefulness and or suppressing REM sleep phenomena. But unfortunately, most of the patients still complain about residual symptoms, even if we often propose polypharmacy for the patient. If I come back to John, we did propose the polypharmacy. We changed time to time, venlafaxine to oxybate in addition to the modafinil. But after 5 years of treatment, we decided to propose a new treatment for John because he was still sleepy. A poor sleepiness scale was around 14. The cataplexy was still 4-6 cataplexy per week. So it was better than it was, but he was not completely satisfied with the drug intake, and he did still have some altered quality of life and problem to work correctly. So we proposed John to participate in one of the phase 3 trials of Oveporexton. I want to detail a bit the two study design of Oveporexton, the phase 3 trial, namely First Light and Radiant Lights. The primary endpoint of these two studies were to assess the objective wakefulness, so the mean wakefulness test latency. The key secondary endpoint was a poor sleepiness scale to assess daytime sleepiness and the weekly cataplexy rate. We were lucky with this, the results of these two studies with green light for the primary secondary endpoint. So in terms of MWT, ESS, and WCR for weekly cataplexy rate. This has been reached at week 12, which was the endpoint of the study, but already assessed at week 4 and week 8 as well. So that the patients are really improved for these three symptoms: wakefulness, sleepiness, cataplexy, but we did see also improvement on hallucination, sleep paralysis, and quality of life, with clinically significant and statistically significant improvement. Regarding the safety, it was well-tolerated drugs, but we did see some AEs, especially insomnia and urinary urgency and urinary frequency, depending on the dose. but at the end it is mostly mild to moderate. And this is on-target effect. It was expected and seen also in the phase 2 trial with the compounds. Coming back to John participated in the open label study, the long-term extension study following this double-blind study that compare again the drugs to the placebo. After 3 months, there are few AEs that disappear over time. Insomnia and urinary frequency disappear after a few weeks. Other orexin-2 receptor agonists were also in development in phase 2 studies, the alixorexton and orexin 750, with some results of interest, especially for alixorexton for objective wakefulness and daytime sleepiness. The other are not well advanced to report on the results so far. If I want to conclude where we are, I think that we better understand the pathophysiology of narcolepsy. We can now really link the orexin deficiency to some of the key symptoms of narcolepsy. The treatment landscape is highly evolving from the current guidelines, European guidelines, American guidelines, with different drugs that help a lot of the patient, but is not ideal because of the polypharmacy and some residual symptoms, namely sleepiness and cataplexy. And with the orexin receptor 2 agonist, we are lucky to really improve care of the patient, to improve quality of life, to really decrease the burden of the disease. And I think that will be a key game changer for the management of the patient in the coming months.